Hello and welcome to Neobiotech International Virtual Seminar. Thank you for attending this webinar, and my name is PHILOSOPHIES. I'm gonna be your host tonight. Before we start today's webinar, I would like to briefly introduce about schedule in this month. Dr. Garlini from Italy, who is an old friend of Neobiotech as a GAO member, gratefully is here for us, and the lecture will be in English. On 29th, which is next week, Dr. Murad from Jordan will present the lecture. For August, next month, our lecturers will continuously present their knowledge to share on every Wednesday. As the first lecture of August, which is 5th, Dr. Christopher C.K. Ho from Australia will be with us. On August 12th, Dr. Sale Park from US, a former professor at UCLA, is scheduled to share his agenda about implant stability. These two lectures will be in English, and the other following two lectures will be in Spanish. On 19th, Dr. Daniel Carcamo from Spain will present a lecture, and for the last term of August, on 26th, Dr. Prada from Chile will join us to share his knowledge. These last two lectures will be presented in Spanish. We would like to welcome you all anytime. Please be advised that there is no translation service in different languages other than the lecturer speaks. And also please notice that all the lecture schedule is based on the GMT hour. It's Greenwich Region time in England. So you will either be informed by your distributors or managers, or you just need to Google to figure out lecture time in your time zone. Alright, for today's webinar, Dr. Garlini from Italy will speak about how to achieve optimal aesthetic with post-extractive implants and immediate function, tips and tricks. He will kindly share his experience and knowledge for about an hour. During the webinar, if you have any questions, please use the chat button to communicate with me about any issues other than the topic. We'll have Q&A session after the lecture, so please submit your questions through Q&A button. Dr. Garlini may not answer for all the questions because we have limited time to take the answers for all. If you have more questions or anything for discussion, you can contact Neobiotech website, which is neobiotech.com, or find Neobiotech Global Department on Facebook. So from now on, let's have Dr. Garlini to start. Please welcome Dr. Garlini. Hello, doctor, how are you?
Hello, Shin. Thank you for your kind presentation. And I would like to thank everybody who is present in this webinar. I can see people from all over the world. I hope that you are all in safe and peace and that you are doing well. So I start to share my screen. And for this lecture, I will present my clinical practice. I will show you some tips and tricks to try to achieve optimal aesthetic in post-extractive implant and immediate function. I think that probably you will have some question for me, so don't be shy. Make any question you want. I try to answer them during the webinar, or I will answer at the end. But if you have any question, it's very important for me to know which question you have. So now, sorry, just one moment. I have a small problem. I have to stop share one moment and to enter again. Okay. As always, you try, you make rehearsal every time and something always might go wrong. So, okay, let's start. Now it's working. If everybody are here this evening, we have to thanks to Professor Brito, who in 1977 introduced to us his very important study about osseointegrated implant. And we must remember that at that time, implants were used only to recreate function for the patient, not to recreate aesthetic. But now, 2020, we know that something has changed. We can use implant for aesthetic, to obtain aesthetic. We can use implant with post-extractive technique for the functional or immediate loading. We can use custom abutment, computer-aided implantology, short implant, and so on. So everything has changed from the time of Professor Brennemark. But we must remember that the dream of a patient that comes in our office is to come in the office with one tooth that must be extracted, and to extract the tooth, insert an immediate implant, and insert an immediate provisional crown. After some months, after 1 year, when you will have the healing of the soft and hard tissue, you can perform the final restoration. But please remember that very important for the patient is to realize a new tooth, a new crown. The patient doesn't matter which kind of implant you will use, which kind of technique you will use. He only asks to you, please, doctor, I want a new tooth and I want a nice tooth. So, first of all, I would like to give you some example. And this is a young lady. She was 30 at the time of the end of this rehabilitation. And this is how she came in my office. After that, she had 2 immediate post-extractive implant and 2 immediate provisional crown. But this was the final rehabilitation, not the provisional rehabilitation. So I think that now it is not correct for our patient to end our work in a situation like this. It's not anymore acceptable to rehabilitate a patient and to end with the final crown in a very bad aesthetic solution, with a very bad aesthetic solution. Let me show you another patient. This is another young lady. She was 35 at the time, and she came in my office. She was desperate because her previous dentist, when she had a problem with one tooth, he extracted the tooth and inserted an implant, and so on. And after 6 implants in the upper jaw and 1 implant in the lower jaw, this was the situation of the young lady, of Enrica, with her provisional crown. So once again, I think that it is not anymore acceptable to leave the patient in this situation, because we took 4 years and 12 surgery to transform her from the picture on your left to the picture on your right. And now Enrica can smile again. But I think that in now 2020, we are obliged to give also aesthetic to our patient, not only function as 40 years ago. So we must remember that we are in the fast food century, and the patient came in the office requesting us immediate implant, immediate prosthesis, immediate success. But on the other hand, we have the implant company that want to push us to insert immediate implant and immediate prosthesis. So our work could be a nightmare if we don't have clear ideas, if we don't have a correct treatment planning. So what we have learned over these 40 years, 30 years, we have learned that of great importance is the treatment planning. Today, we do not have enough time to go inside every key factor that you can see in this slide. But please remember, every key factor is very important to obtain success, and especially to obtain a very nice aesthetic final result. Today, I would like to stress the fact that from last 20 years, we had a great change in the treatment time. Why? Because more or less 20 or 15 years ago, when I have to extract one tooth in the posterior area, as you can see here in the picture on your left, or I had to remove an implant, as you can see, and on your right, I was used to remove the implant, to extract the tooth, to wait at least 3 or 4 months for the healing of the soft tissue, of the hard tissue, and then perform the implant with or without any regenerative technique. And once again, after 3, 4, 5, or 6 months, we were able to realize a provisional crown, and after the provisional crown, a definitive crown. So I had the same approach 15 or 20 years ago. And if I have to rehabilitate the lower or the upper arch, if I had some hopeless teeth, I was used to extract them, waiting with a provisional restoration for the healing of the soft and hard tissue, and after 3 or 4 months, insert the implant, wait again for the healing and the osseointegration of the implant, and then realize the final prosthesis. But everybody knows that in 1997, some author started to publish some articles about immediate loading, like the ones of Tarno or Balshi. And after them, there was the publication of Paul Malo. Paul Malo did a lot of publication about immediate loading. So if we go into PubMed and we type the words immediate loading implants, from 1977 to 2020, you can find more than 3,000 of publication. And if you go deeper inside the question, if you type placement of implants into a fresh extraction socket, you will see that from 1991 to 2020, you will see more than 300 results. That's why in the last 15 years, I changed my approach. So usually I try to do every time when it's possible, immediate implant. Obviously, I started to use this approach with the complete arch rehabilitation. So I started to do this with a situation like this, where I have to extract all the tooth, all the teeth, and to insert the implant, to take an impression, and to realize an immediate provisional restoration. So the patient came in the office with his own teeth, and he went out of the office with new teeth, provisional teeth, screwed into the implant. We can do this approach not only for one arch, but you can do also a double arch rehabilitation with immediate implants, post-extractive implants. Obviously, it is a little bit more tricky, but you can use this approach every time you can. And so in a situation like this, it is very easy to extract all the tooth, insert some implants, 4 implants in the upper jaw and 4 implants in the lower jaw, and to splint them with a provisional screwed prosthesis, 1 in the upper and 1 in the lower jaw. Obviously, after the experience of the complete arch, we tried to treat with this method also the single tooth. So we started to try this, to do this approach also when we have to extract one tooth, for example, like in this situation for the presence of a root fracture, and insert the implant, insert a provisional crown, and the patient can go out of your office with a new tooth screwed into the implant. So you will have to wait for the healing. Once again, you have to wait for the healing of the soft and hard tissue, but you will not have to perform any surgery. And after the healing, you are able to realize a new restoration screwed over, a final restoration screwed over the implant. Obviously, you can have the same approach in the posterior area. When I have to extract the tooth in the posterior area and I don't have any situation of infection, I can extract the tooth and insert an immediate implant. Then we will discuss later about the importance to make a bone graft and obviously also a soft tissue graft, but maybe in the posterior area you can make only the bone graft, and after 3 months you will have a very nice healing ready for the final rehabilitation. Obviously, if you work in the posterior area, you can choose between immediate function or not. And probably in this situation, the best solution will be not to perform the immediate function. But sometimes we have patients that ask us the possibility to have an immediate crown. So if you want and you have enough stability, you can also perform the immediate provisional crown. 1 year ago, the European Academy of Osseointegration sent a survey to all the members, and during this survey, there were some questions. One of the questions was, do you believe immediate implant will be placement after tooth extraction will be more frequent, similar, or less in the next 10 years? And you can see here the result of the survey. 61% consider more frequent than now the immediate placement after the tooth extraction. And what about the immediate loading protocol? Do you believe that it will be more frequent, similar, or less in 2030, so in the next 10 years? Once again, the answer was clear. More than 2/3 of the clinician consider more frequent the immediate loading protocol, and 1/3 similar. So we think that in future, the immediate post-extractive implant will be something that everybody will do in his office. I think that in my office, in my clinical situation, immediate post-extractive implant with or without a provisional prosthesis is the ideal solution. So every time I have to deal with this technique. And I will try to explain which are the reasons for me to do this and how you can maximize the aesthetic result with this method. Let me show you this case. We have an implant rehabilitation. We have one molar and one premolar screwed over two implant just at the end of the prosthetic rehabilitation. We can see that we have a pretty nice result. And if you see the picture on your left, we have also a good amount of keratinized tissue. And this was a conventional implant insertion, so not an immediate post-extractive implant insertion. So we extract the tooth, waited for 3 months, insert the implant, then wait again 3 months and perform the final rehabilitation without any provisional crown. And what I would like to underline to you is that during the 6 months of healing of the hard and soft tissue and of the implant, we lost a great amount of buccal bone. If you can see the arrow of my mouse, here you can see the natural tooth with his vestibular bone surrounding him with the keratinized mucosa. This is an implant, and you can see that we lost some bone. We had enough bone to insert the implant, so I did not perform any regenerative technique, but you can see very easily that we lose some buccal bone. And also, or especially in the molar area, we lose a great amount of bone. I think that this patient, when he will chewing, he will impact all the food in this area, and probably he will come in your office at the checkup control in the next 10, 20 years, and he will say to you, "Doctor, very nice tooth, I can chewing everything I want, but every time I chewing, I had to clean my teeth because I have some food impacted in this area." So let me show you another situation. Here I had to insert two implants, one in the first molar and one for the second molar. But as you can see here, I still have the roots of the first molar, so I perform a post-extractive implant, immediate implant, and I perform a delayed implant in the second molar area because the tooth was extracted years ago. You can see here the two implants inserted. You can see here the bone graft and also the collagen membrane covering the area. I used to insert at this time collagen membrane in this case. This is a pretty old case. I think I performed this case 10 years ago, more or less. And you can see here the healing after 3 months, and you can see here the final rehabilitation just screwed in. Once again, you can see that we have in the first molar, we have the maintenance of the vestibular bone, of the bundle bone, and we do not have any bone vestibulary to the second molar. There was enough bone to insert a 4.0 or a 4.5 millimeter implant, but once again, probably this patient will have food impaction in this area. So that's why every time I can, I prefer to extract the tooth, insert the implant, to make a little bone graft just around the implant, and to use some collagen to cover the space between the keratinized mucosa and the implant. So this is the X-ray just at the end of the surgery. And after 3 months, you can see here a very nice healing. In all these cases, I just perform post-extractive implant in the posterior area without any provisional, okay? And here you can see the final situation with the implant screwed in. Another situation, I had to extract the second premolar and the first molar and the lower arch, and once again, insertion of the implant, post-extractive implant, insertion of a bone graft, and 3 months of healing. And you can see that after 3 months, you will have a very nice healing. You will have the maintenance of the bone in the vestibular component. So this situation is more interesting if you consider the anterior area. Obviously, in the anterior area, we have to insert not only the implant, the bone graft, and also, as I will show you later on, a soft tissue graft, but we have to insert the provisional crown because the patient will not leave your office without a provisional crown. So I will discuss about the characteristic of a provisional crown later on, but once again, this is the situation on the left just after the surgery. This is the situation 6 months later. And you can see here that we have all the buccal bone vestibulary to the implant. This is a canine, and we have all the buccal bone over the canine that was maintained. And this is the final rehabilitation. Obviously, in a very few number of cases, I cannot perform in the anterior area this method, especially when I have, as you can see here, suppuration and maybe also a fistula like this. This tooth was fractured and there was also suppuration from the fistula, so I prefer a delayed approach. But obviously, when you're planning a delayed approach, you have to deal with soft tissue and hard tissue resorption. So you have to deal with implant insertion, with the possibility to collect some bone, for example, with the ACM burr here from the retromolar area. Sorry for the sirens outside. And to perform a regenerative technique with a titanium mesh. So we have to wait for 6 months. After 6 months, we perform the re-entry, we took a digital impression, and we insert a provisional. And now we have to wait again for the soft tissue healing. At least we have to wait 1 year or more. So this is the final situation, which is ended up about 1.5 years after the extraction. So I think that we are in front of 2 different treatment philosophies. If you perform delayed implant, and as we can see later on, you have also to improve what is there. So which is the rationale to do an immediate implant? Obviously, as I have already said, the preservation of the site and of the alveolar bone, and you will have to improve, I must say, the alveolar bone, and we will discuss later on about this. You will have an easier provisional management. You will not have to deal with Maryland bridge, with removable prosthesis, so more comfort for the patient. Remember, for the patient has a dream. Came in your office with his tooth and to go out with a new fixed provisional crown. You will have less risk of papilla loss during surgical procedure, and obviously you will have a faster healing, a reduced treatment time. You will perform less surgery, and the patient will be very happy of this fact. So which are the key factors that we have to consider to obtain an excellent aesthetic result if we have to deal with the anterior area? Because up to now, I have shown to you some cases in the posterior area, and probably the posterior area is an easy area to approach with a post-extractive implant. The anterior area will be more challenging, but probably will be not any more challenging for you if you keep in mind the key factor that we are going to discuss now. So the question now is how we can influence the aesthetic outcome of a soft tissue in the frontal area. And we must keep in mind some key factors. First of all, we must consider the marginal level of the tooth or of the teeth that you have to extract. When you have to extract one tooth, as you can see in this picture, you can have 3 different clinical situations. We can have a situation where the margin of the keratinized mucosa is apical than the margin of the contralateral tooth. In this case, will be probably a very unfavorable case. Also unfavorable is the situation where you have the same level of the tooth that you have to extract and of the contralateral tooth. And more favorable will be the situation where you have a marginal level of the keratinized mucosa which is coronally positioned respect the contralateral tooth. But unfortunately, this happens very rarely. Why is the 2 situations that I have shown to you are unfavorable? Because we are all aware about the recession of the soft tissue and so about the final result. So please, first of all, analyze the marginal levels and then analyze the tissue. Everybody knows that 15% of a patient has thin and scallop tissue and 85% of a patient has thick tissue. So we know that when we have to deal with thin tissue will be probably more challenging for us the situation than we have to deal with thick tissue. How we can understand if our tissue is thick or thin? This is the typical question that probably you can make to a student. If you can see your probe going deeper than 1 millimeter into the sulcus and you can see the probe in transparency under the soft tissue, this is a thin tissue. If you can see probing the tissue around the tooth, a sort of ischemia, and if you can see here that the probe goes into the tissue and you cannot see anymore the probe, probably this will be a thick tissue. Another key factor is the smile line. It will be very challenging to replace these 2 central incisors in this patient with this height smile line, and it will be easier to replace those 2 central incisors with this patient with a very low smile line. So you have to analyze all these factors when you see and you visit your patient. Then we go deeper, another key factor, which is the bone quantity. Everybody knows from the study of Lind, of Araujo, that if we insert an implant into a post-extractive socket without any graft, we can have the osteointegration of the implant and we can have new bone around the implant. because of the jumping distance concept. This is true, but if you analyze the histology of the work of Araujo and Lind, and here on the right, you can see the histology at day 0 when they insert the implant into the extraction socket, after 1 month, and after 3 months, so day 90. And what you can see that the implant is well integrated after 3 months. You can see that new bone is grown around the implant, but you lost the bundle bone. You have lost all this bundle bone. So imagine to have this in the anterior area. This will be a great problem for you. Let me show you one of my first cases. I performed these cases, I think 15 or 16 years ago. I had to extract this tooth because of a root fracture. So I extract the tooth, I insert the implant, I have just read the article of Araujo. I know that here I will have some bone regrowth, so I insert the provisional crown. I screw it in the provisional crown. And this was the healing. Okay, you can see here, 2004, 16 years ago, I insert the final prosthesis. And you can see on your right, the control checkup after 10 years, so 2014. The crown is still pretty good. The keratinized mucosa is good, is not optimal, but is fine. But if you can see the patient, if you take a look to the patient from a lateral point of view, you can see that the implant is not sufficient to maintain the buccal bone, to maintain all the buccal bone volume. Here we have a concavity, and the concavity here means that when the patient smiles, she shows a black area. So please trust me, every time you have to deal with a post-extractive implant insertion, you have to insert also some bone around the implant. You do not have to insert only the implant, because the jumping distance works, but is not enough. So let's go on. Another very important key factor, the implant position. This probably is the most important key factor. You have to keep great attention to this situation, to this implant insertion, because you can insert the implant in 3 different situations. You can insert an implant too much buccal, as you can see in the first image. You can insert the implant just in the center of the post-extractive alveolus, or you can insert the implant too much or in a palatally position. Now, after more than 20 years of post-extractive implant, I can suggest to you that the ideal position is the third one, when you insert the implant slightly palatally, as you can see in this image. So you don't have to go just in the same direction of the tooth, of the root of the tooth, of residual alveolus, but please move a little bit palatally. You will be helped to do as if you analyze the cast stone models of the patient, and if you analyze the diagnostic workup of the patient to understand which is the ideal position in which you have to insert the implant. Today, obviously, we can use virtual diagnostic workup, but the process is the same. You can go digitally or you can go with an analogic method, but the situation is similar. And what is important is to create the correct surgical stent. Usually, I spent 1 hour to speak about the characteristic of the surgical stent, because it is very important to create an ideal surgical stent, to analyze all the parameters and to insert the implant in the ideal position. But obviously, we don't have now we don't have time to stay 1 hour discussing about the surgical stent, but you have to use, especially for your first surgery, the surgical stent, because it's very, very helpful. And another suggestion that I have to use to you is to utilize a very thin burr if you are dealing with a delayed site, as you can see here, or if you are dealing with a post-extractive implant. Because if you have a very thin burr, you can exactly insert the implant in the correct position. You can drill exactly where you want. The drill will not slippery inside the alveolus. I use this kind of burr, which in Italy we call ferox. But you can use other method. For example, you can use a magnetic method, which is a manual method, so you can prepare the site with this kind of technique and go with the burr just after that you have decided which will be the final position of the implant. But please take attention to this fact, because if you insert the implant too much buccally, you will have a very thin bundle bone and you will compress it with the implant, with the prosthesis, and compression means resorption. So you will have probably a recession. And you can see here 2 of my initial cases where I had some recession because the implant were not inserted in the correct position. If you stay inside into the post-extractive area, probably you will have a good aesthetic final result, but you must perform a cemented crown. And now, in the last 10 years, I prefer to perform screwed crown. So if you stay slightly palatally, you can screw it in your crown without any cementum, and it will be very easy to manage the soft tissue, and you will not have any recession. So please take care of this. I will show, for example, this patient that I saw in my office more or less 1 year ago, so not a lot of time ago. And this was an old lady. She was 80, but she is still in good condition. She had to extract the anterior teeth, and she wanted a fixed bridge with an immediate restoration. But the doctor, at the end of the surgery, said to the patient that there was no possibility to perform a fixed prosthesis. So he inserted the implant and he said goodbye to the patient with a removable prosthesis. Why the doctor said that? Because when I opened the implant and I tried to realize a fixed prosthesis, this was the inclination of the implant. So obviously those implants are very buccally inserted, but if you insert the implant too much buccally, you will have 100% resorption. So you will not have a very nice aesthetic result. And it has been very tricky for me to realize a fixed prosthesis. I had to utilize some multi-units to create a straight position for the screwed restoration. So take attention also to the mesiodistal position. You must have at least 1.5 2 millimeter between the adjacent teeth and the implant. So don't use too much bigger implant. and go deeper 3 millimeter under the cementum junction or under the free gingival mucosa. So this is important, but the most important thing is to do the correct implant insertion with the correct position. Let's go on with another key factor, which is the biotype conversion. As I told in the first minutes of this webinar, very important is to maintain the soft and hard tissue, but also to improve soft and hard tissue. We have already spoken about the necessity to do a bone tissue graft, but you have also to improve the soft tissue. So you have to perform a connective tissue graft. Always in the anterior area, I perform a connective tissue graft, or I use, as we will see later on, some tissue matrix. In the posterior area, I perform only the bone graft, not also the connective tissue graft, but from canine to canine, I usually perform connective tissue graft. We have learned how to do this connective tissue graft in the 2000 from the study of Grunder. So it is 20 years that we deal with this concept. And every time that the patient allows me, I perform this kind of procedure. But sometimes the patient does not allow me to do a connective tissue graft, because now the patient is very well informed. He can go in internet and understand if there is any substitute of the connective tissue. So we can use, for example, tissue matrix, and there are few tissue matrix present on the market, and this lady, for example, didn't allow me to perform a connective tissue graft. So I perform, as you can see here, the insertion of a tissue matrix between the keratinized mucosal and the alveolar and the residual alveolar vestibular bone. So we insert the implant, we insert the provisional, and after 1 year, we were ready for the final crown. We had a nice soft tissue healing, and we had the maintenance of the buccal bone of the profile of the central incisor. So this was the final situation. Few months ago, about 6 months ago, I started to deal with this new material, which is a porcine connective tissue. It is a connective tissue taken from the pork, and you will have a great quantity of connective tissue. You can choose between different sites, and so it's very easy to use this kind of tissue. You don't have to go to take the tissue from the palate, but I don't have cases with longer-term follow-up, because I started to use this kind of material in November. So I can show you this case, for example, but I don't have a great follow-up. This patient has to extract the central and the lateral right incisor. You can see here which was the situation. We had performed the virtual diagnostic workup, the surgical stand, everything that is necessary, the provisional, and we go on with the surgery. We extract the tooth, we insert the implant into the correct position, and we perform the bone graft around the implant, and also the connective soft tissue graft between the keratinized mucosal and the residual portion of the alveolar bone. This was the situation when I checked the position of my two provisional crown, and with my technician, we have realized two provisional crowns that are also the surgical stent, and we can fix them over the two adjacent teeth. So we prepare and we reline the two provisional crowns. This was the situation when the patient left the office, and this was the situation 1 month just after the surgery. On the left, the situation before the surgery, and on the right, the situation, but just 1 month after the surgery. So I don't have any long-term follow-up. I can say that is a very interesting material because it's very easy to manage this kind of material. And I know that to maintain the volume of the buccal bone of the vestibular bone, we can use also the socket shield technique that was proposed by Marcus Hürseler 10 years, more or less 10 years ago. And with this technique, you can maintain the vestibular part of the root in order to don't have a very thin layer of bundle bone, and so you can maintain in a very simple way the vestibular component of the alveolar sulcus. But I really don't like this technique because I don't think it's very easy for me to prepare the thin layer of the root of the tooth, and also that I think that probably there might be in Italy some medical problem if, for example, I will have perimplantitis around this implant. So usually I prefer to use this kind of method only in old patients. For example, in this patient, she was 83 years old, and I don't want to perform any connective tissue graft, any bone graft. So I think it was easier for the patient just to extract the tooth and to prepare, extract partially the tooth and to prepare the vestibular part before the implant insertion. With this technique, you can have a very good maintenance of the bone volume in the vestibular part. But as I told you, this is the final restoration of this old patient, 83 years old at the time of the final restoration. But usually I prefer not to deal with this kind of procedure. And so now let's go to the last key factor, which is last but not least, because probably is the most important thing. The provisional crown and the abutment design has a very important key role in the final aesthetic result. First of all, you have to choose the correct temporary abutment. And I think that the temporary abutment of the Neobiotech implant system is a very interesting abutment from this point of view, because you can choose between different length and different diameter of abutment. And this is very, very important. Why? Because you can deal with different situations. Sorry, if you have different length abutment. You can deal with a situation where you have a very minimum quantity of space between the upper jaw, for example, and the lower jaw to create a provisional crown. But you have to deal in situation where you have a great space and you need a very long temporary abutment. I have tried different kind of abutment, and sometimes the temporary abutment are not enough in length to perform a good provisional crown. With this technique, for example, with this temporary abutment, you can utilize as a temporary the crown of a patient of the root that you have to extract. This patient has this root with a very big decay, and we decided to extract the root, insert the implant, and to utilize as a provisional crown the zirconia crown that was already present over this tooth. So we extract the tooth, we insert the bone graft. In this case, it's not necessary to perform the connective tissue maybe, and we align the zirconia crown and we screw it in the zirconia crown just after the surgery. And this is the situation of 1 week after the surgery. And you can see here the zirconia crown connected with the temporary abutment. And you can see here some spaces because we have the acrylic resin here over there. The problem of this technique probably will be that the patient will stay longer than 1 year with this provisional crown. So you have to deal with this fact. The key factor with a provisional crown is the shape of the provisional to create the correct emergency profile. And please don't do any convex profile, but please perform a concave profile. Why? Because convex profile create compression, and compression over the tissue create ischemia, and ischemia means resorption of the soft tissue and of the hard tissue. So when we had to shape our provisional, we have to shape the provisional with a concavity, 360-degree concavity all around the provisional crown. With this method, you will have the possibility to increase your soft tissue and to have a very good quality soft tissue, after the healing. With my friend Marco Redemagni, we published more than 10 years ago, in 2009, a very interesting study in the European Journal of Aesthetic Dentistry about soft tissue stability with concave abutments. And we understand that if we perform concave abutment, we will have a very good quality of the soft tissue around the implant. If you unscrew the provisional crown, you will have some connective tissue fibers which go horizontally over, around the provisional crown that create a sort of suction. So it will be very difficult for you to remove the crown, also if you have unscrewed the provisional. The problem might be the possibility to transfer this information to the lab. Why? Because once you have a concave abutment and you use a standard transfer to take an impression, you will not give this very important information to the lab. So you need to create an individual abutment, an individual transfer, and you must utilize the HINS technique, which was published more than 23 years ago. Why? For example, I go back a little bit. First of all, you have to unscrew the crown from the implant and to connect the crown with the implant analog. Then you take some polyether material, some impression material, and you put all this complex, the provisional crown and the implant analog, inside of the impression material. After a few minutes, you can unscrew the provisional and you will have the copy of the emergency profile. And you can see in the central image that if you are going to use a standard transfer, you will miss all this information for the lab. So you have to add some acrylic resin, you can add some composite, if you want, you can add some pattern resin. I prefer the acrylic resin around the transfer, and you can go back to the mouth of the patient to take the impression. When you will finish with your impression, the transfer will be inside. You can bring everything to the lab, and the lab will develop this stone model with the correct emergency profile. And so the final crown will have the correct emergency profile, and you will have very nice tissue around your implant, and you will have a very nice situation also from an aesthetic point of view, not only from a functional point of view. Obviously, you can do this directly inside into the mouth of the patient, but I don't like to do this with the acrylic resin or with the composite directly inside around the implant, because I think that you will have some tissue contraction, you will have less detail, and it is more difficult to manage for you and for the patient. So I prefer to do this separately. But today I go digitally, so I will not take anymore this kind of impression, because I will take digital impression. So I will use scan abutment, and I will use scansion of the area where I have to perform the final rehabilitation with the scan abutment. And also you have to scan not only the scan abutment, but you have to scan also the provisional crown, because if you scan also the provisional crown, it will be possible for the lab to match the two files, to match the two images, and to create the correct crown with final crown with the correct emergency profile. So now the question is, we have understand that every time that I perform immediate post-extractive implant, and every time that I perform also immediate provisional screwed over this implant. But can we do this only in the anterior area? No, we can do this also in the posterior area. We can do this also with sinus lift. We can do this also with GBR. But please keep in mind, never do this with the last tooth of the arch, because it is very dangerous. Obviously, you can do an immediate implant, an immediate post-extractive implant for the last tooth of the arch, if you have a possibility, but never do an immediate provisional crown in the last tooth of the arch. You can do this situation for multiple implants in the anterior area. We had to extract the two lower canine, and we insert the two implant with a provisional screwed restoration immediately inserted, and after 6 months we had this kind of healing. And once again, you can see that with the bone graft, with the soft tissue graft, you can maintain the volume of the bone, you can maintain the contour of the bone, and so you can realize this final restoration screwed over the implant. Obviously, you can treat multiple areas. For example, the lower inferior arch, if you need to treat this area with the same situation, with the same technique. It is very easy to do this, but you have only to keep in mind the concept that we have discussed before. And before I end my webinar, I would like to show you that you can do also a sinus lift procedure and also a small regeneration when you have to extract a tooth like this And the lady said, no, doctor, I don't want to stay without my tooth for 6 months. So you can perform the tooth extraction, the implant insertion, the regeneration, and a very small crestal sinus lift procedure, as I will show you later on. Once again, you have to realign the provisional, you have to create a concave emergency profile in order to have the correct healing of the soft tissue. And after 6 months, you will be ready for the final prosthesis. And once again, you can see that you have no loss of the buccal bone. You will have no concavity in this area. So this is an old case, more than 5 years ago. You can perform the impression. This was an analogic impression, regular impression, but you can perform also with this technique your final screw restoration. And you can see here that we had a very small amount of bone into the sinus with a crestal approach. So, dear colleagues, I am at the end of my presentation, and before I hand it, I would like to present you an article that we published 3 years ago, because sometimes when I present the concave profile, the question of the audience was, how can the patient clean this concave profile? And the answer was, the patient has not to clean over there. He has not to clean deeper around the implant. But I had to think about that. And so I started to analyze the soft tissue response after 10 years of single post-extractive implant with immediate loading. And once again, together with my wife and my friend Marco and another friend of us, Angelo Calderini, we published this article. And after 10 years, we had a 98.6 survival rate, which is quite good after 10 years. And please remember that we performed this implant, 147 implant between 2002 and 2005. So we don't have the knowledge that we have now after 20 years. But we still have a very good survival rate, a very low beating on probing, and the pocket probing depth was 2.75 after 10 years. So it's a very good result, I think. So please, dear colleague, I am at the end. Please keep in mind, you don't have to be a superhero, but you have to make things simpler, but not as simple as possible. Thanks for your kind attention, and I am here to wait for your question if you have some question for me. Okay, let's go in the chat box. I see some friend from Italy and from Georgia. We can wait for some minutes. If you have any question, please don't be shy. I try to answer to your question. In Italy is quite dinner time, and I know that in Asia is night, so probably you need to take a cup of coffee to stay awake. So maybe, maybe there is, this is a comment of a friend of mine. Thank you. Thank you so much. Thank you. If you have any question, I am here to answer to your question. Here you can see my email, my LinkedIn and Facebook contact. If you have question in future, maybe when you try to do this technique, please don't be shy, send me an email, send me a message, and I will try to help you from Italy by the social or by email.
Right, thank you, Dr. Garlini. And it's
Thank
my
you.
turn now again. Let me share.
I stop to share and I say bye-bye to everybody.
Thank you very much for your lecture, Dr. Garlini. Please stay connected with Neobiotech social media to communicate with us more. Search Neobiotech Global Department on Facebook or Neobiotech on YouTube. Please click follow, like, and subscribe to get more updated news. This lecture will be uploaded in our website also as on our YouTube channel, so you can review this lecture later at any time. For the next upcoming webinar, it will be on 29th, which is next Wednesday. Dr. Murad will be with us to present the lecture. The title is Predictable Ridge Augmentation and Preservation, Decision Making and Techniques. And the lecture is in English. Please remind that we do not have any translation service. If you have any questions or need more information, please email us to either bees@neobiotech.com or gabriel.lee@neobiotech.com. And we have more information in our website and social network service as YouTube and Facebook. And we are very happy to take your opinion on today's webinar. Please share a minute for us. There will be an extra pop-up screen, just like this, you can see. And they have only 5 questions. Thank you very much for your participation. And Neobiotech will always try hardest to improve the quality of your satisfaction. Right, let me start the survey. And I'll hide the answers. Thank you all for being with us tonight. And thank you, Dr. Garlini, again for your presentation. We'll see you in next week. Have a great night. I will leave the survey page open a couple more minutes for you to finish. Thank you all.